You are joining us for When Trauma Reactions and Neurodevelopmental Disorders Overlap. Today's training will focus on the characteristics of trauma-related disorders and neurodevelopmental disorders, such as autism spectrum disorder and attention deficit hyperactivity disorder, in children ages birth through 5 years. Our presenters will review complex presentations and highlight the overlap and distinctions. In addition, they'll explain how broadening your perspective can help you to better understand a child's needs and link families to services to promote positive outcomes. Our panel of presenters today, which you see here, include 3 licensed clinical psychologists from the Developmental Evaluation Clinic at Rady Children's Hospital, San Diego. Rady's is also home to Caltrans, so we love having them join us. Dr. Yanan Guo provides comprehensive evaluations for children aged birth through 5 with developmental, mental health, medical, and family needs. She also provides developmental evaluations for Rady's Kids Start program, which is a program also for children aged 0 to 5 with complex developmental and mental health needs. Yanan is also a board certified behavior analyst, and she specialized in working with individuals with autism before starting her doctorate program, providing behavioral services and parent training. Dr. Megan Lukasic brings more than 2 decades of clinical experience to her work at Rady Children's, where she also specializes in the assessment of infants and young children. She has extensive experience in diagnostic assessment of neurodevelopmental disorders and early mental health concerns, including childhood trauma. In addition to providing direct clinical service, Megan manages the Developmental Evaluation Clinic and is the co-training director for the clinic's postdoc fellowship program. And we also welcome Mercedes Pratt. Prior to joining the Developmental Evaluation Clinic in 2022, Dr. Pratt gained specialized experience working with young children with autism spectrum disorders and developmental delays through her postdoctoral fellowship at the University of Texas Southwestern Medical Center, Children's Health Center for Autism and Developmental Disabilities. In her current role, Mercedes specializes in comprehensive diagnostic evaluations for developmental and mental health related concerns. Her goal is to provide compassionate care, help families understand their child's strengths and challenges, and guide them toward valuable services. So you can see we have an amazing group of presenters today with a real depth of experience, both in neurodevelopmental disorders and in trauma. And so I'd like to welcome Yana, Megan, and Mercedes, and I'm going to turn it over to you now.
All right, thank you so much for the warm welcome, Dana, and we're very happy to be here. And thank you, for everyone for joining us. We're very excited to be sharing the next couple hours with all of you. So before we get started, I would like to orientate all of you to kind of our agenda or our objectives for today. We have a lot of great things planned out for you guys. So we'll be looking at some of the characteristics of some of the more commonly seen neurodevelopmental disorders, specifically autism spectrum disorder or autism, and the attention deficit hyperactivity disorders, more commonly known as ADHD. We'll kind of look at childhood trauma and then really its impact on the child's development and then how they sometimes manifest in behaviors or other challenges that we see when we're working with the child and the family. We'll look at and discuss kind of different treatment or therapy options available. And then more importantly, we're also going to be looking at kind of the overlaps between these neurodevelopmental disorders and trauma, and then kind of some of the distinctions that we see in them. And as Dana mentioned, we have a breakout group planned for all of you today. So we'll be looking at a case together and then really looking at why trauma-informed and developmentally informed approaches, is really important when we're working with children who have all these different challenges and needs. And then how do we, as providers or as, just people that come in contact with families, how do we sort of like broaden our own perspective so that we're promoting positive outcomes for these families? And then we'll look at kind of, again, the importance of these flexible perspectives and then the value of assessment over time or treatment over time in really kind of getting our understanding for the child and then the family. Okay, before we go into our great content, we like to learn a little bit more about all of you guys. So we would like to to know, for you to participate in a poll, for you to share a little bit more about kind of what is your role in your current work. There are a couple ways that you can participate in this poll, where in this response. So the first way is if you would take out your phone, pull up your camera, and if you could just hold it up to the QR code that you see on the screen right now. And once you see a link pop up on your camera, feel free to click on that. It should take you to our poll question directly, and then you will be able to type in a response. And alternatively, you can also go to your internet browser, go to menti.com. Once you're on that page, you should see an option for you to type in the code. So you can type in the code that you see on the top of the screen. I see we have a lot of really tech savvy people. The response is already coming in. Alternatively, if you're having issues with your phone, feel free to drop that in the chat as well. So we have a lot of different disciplines here today. So we have care coordinators, social workers, developmental specialists, case managers, mental health therapists, professors, program managers, family engagement liaison, I like that, event coordinator, community mental health, child welfare, admin, peer advocate, behavioral specialist, victim advocate, and then prevention specialist, trauma-informed consultant. Wow. County administrator, preschool teacher, case review officer, CASA, psychologist, therapist trainee, educator. Wow. And then the responses are just coming in. Let's see. Parent partner. We do have that at our Marietta location as well. Parent coach and trainer, resource specialist, program manager, I think I said that one, special ed attorney, peer advocate. Awesome. All right. So we have a lot of different disciplines here, and then I think it's really great. I think our breakout discussion is going to be great because we love to hear kind of how each discipline, kind of how your role really impacts, in terms of getting connected with resources and really understanding these families' needs. Awesome. All right. Okay. Let's get back to the slide. Okay, so to start us off, I would like to talk a little bit more about kind of autism spectrum disorder. That's one of the more commonly seen neurodevelopmental disorders in our work. Autism spectrum disorder, or autism, or ASD. There are different names for it, but essentially it's a neurodevelopmental condition or disorder that really kind of some of the core features include differences in social communication, and then really the presence of restricted interest and repetitive behavior. So when we look at autism, or when we look at some of the core features, the first thing is looking at their social communication. So when we think about social communication, we're really looking at how are they initiating interaction within that social context? How is their responsiveness? Like if someone were to engage them in playing, are they responding to that? Or, are they more so just kind of keeping it to themselves? And then we're also looking at, so that's kind of some of the things that we would look at for maybe a younger child. For someone that's a little bit older, like 5 years old or 6 years old or older, sometimes we're also looking at their insights into social relationships. Do they understand what friendship means? Do they kind of have an understanding of how to make friends, or why someone is a friend to them? So again, we're looking at more of that subtle or more abstract social relationships. And when we look at their kind of restricted interest and repetitive behavior, some of the things that we kind of see in younger children will be they just love dinosaurs. That's the only thing that they want to play with, where they just love cars, they love Barbies. So they have these things, toys or activities that they just absolutely love, and then that's all they want to do. And then when we look at repetitive behaviors, they also come in different kind of forms. So for some kids, that might be kind of when they're playing with a car, all they do is rolling the car back and forth. That's the only thing that they do. So kind of playing with the toys the same way over and over again. We're engaging the same play script, like whenever they're playing, kind of doing pretend play with their dolls or their stuffed animals. And then some of these can also be a little bit more apparent. So things like repetitive body movements. When they get excited, they flap their hands, where they like to pace back and forth in the room, and things like that. So one of the things I want to point out is that when we talk about restricted interest, especially, we're really looking at, is that developmentally appropriate? How much a child loves a specific activity? It's a very, I think, developmentally appropriate for a 2-year-old or 3-year-old to love to be playing with cars or dinosaurs. But if that's the only thing that they want to do, anytime they don't have their dinosaurs, they get really upset. Or when they go to the playground, instead of playing with the other kids, all they want to do is playing with their cars by themselves. Or when they go to daycare, the other kids are playing with other things and they don't want to. They want to stay with their dinosaur. So I think, when some of these more kind of preference, if you will, become a little bit more impacting of other areas of their development, that's when we want to become a little bit more concerned. And then just some general statistics on autism spectrum. Right now, 1 in 44 children in America is diagnosed with autism spectrum disorder. And then as we know, this rate has just been increasing over the last few years. And autism really doesn't have kind of any racial or ethnic difference in terms of kind of the prevalence that we know. And really the only thing is that, or the other thing is that there's no one cause for autism. We're still very much learning about kind of, the etiology of this specific disorder. And then really the concept of autism is still evolving. Lately, as a society, we're doing better at kind of talking about the language that we use when we're talking about, individuals with autism or autistic individuals. So some of the terms that we use have been changing kind of throughout the years. And really, we're still trying to understand this disorder a little bit more, in particular, kind of how autism is presenting in girls, because we know originally the diagnostic criteria, kind of a lot of those were, or primarily were based on kind of research done with boys. And then as we have come to learn, in the last few years, or, in the last many years, girls present very differently. So they're very much better at masking. So they do a really good job of imitating social interactions. So even if they're not really understanding kind of the nuances of these social relationships, they're able to kind of pick up on those different things and they imitate that. So from a surface level, they are very social. They do understand all these different social relationships. So as a result, we're seeing girls getting diagnosed at a much later age, and it's a little bit harder for them to access services because of that. Let's see. So some of the early signs that we've seen of autism in younger kids particularly are they don't only have a lot of big smiles, or anytime their caregivers smile at them or play with them, they're not necessarily responding to that. And they're not doing a lot of kind of back and forth babbling, or they're not really imitating or paying attention or registering your facial expressions by 9 months. And then again, kind of that lack of language, or that babbling by a year old. And then really a lot of times we see a lack of gesture as well. They're not necessarily pointing, they're not showing you things, they're not reaching, where they're not doing things like waving or shaking their head and things like that. And then really, again, a lack of language, kind of those early words by the age of 16 months, and then really not combining words by like 2 years old. And then one of the other really good indicators that we kind of commonly see is if there has been any loss in their speech, or any skills that they used to have. So we hear sometimes a lot, parents tell us when they come in for the evaluation, oh yeah, he was talking, when he was a year old, that he had all these different words, but then all of a sudden he's not using them anymore. Or they used to do a specific thing. They used to, play with the ball, where they used to do interactive games, but then all of a sudden they're not doing that anymore. So again, any loss of those skills. But the other thing I want to kind of point out is that there is no single behavior. There's not a single behavior that really indicates, okay, this child is autistic. Because autism, as we know, it's a spectrum. It's not a very linear thing. It's made up of a constellation of different symptoms. And then there are some behaviors. So these are some of the behaviors that we see in younger children. However, children that have these symptoms are not necessarily autistic. So sometimes it might mean that they have developmental delay. So that's something really important to keep in mind, is that even though a child might be presenting with some of these things, they might not necessarily be autistic. And then we'll talk a little bit more later on about, the importance of focusing on needs and not so much on the label or the diagnoses. And then sometimes, it's really hard to, like, when you think about this, like if you have your own kids or if you work with younger kids, you might think about, okay, like what is developmentally appropriate? Like how much should he really be talking? How much should he be playing? So one of the things, we like to think about is like, if you picture like a typical like neurodevelopmentally kind of developing the appropriate toddler, like how much should they be talking? If you're around kids that are developing really nicely, how much language should they have, or how much interaction should they have with you within that social context? So now talking about some of the more kind of therapy that are really focused on addressing some of the challenges that we see in kids that are autistic. So some of the more kind of commonly seen early intervention services include speech and language therapy. So really addressing their communication, sometimes their play skills, occupational therapy to really looking at some of their motor development, specifically fine motor development. Also, a lot of times occupational therapy works on sensory needs or feeding and things like that. And also applied behavior analysis, or ABA. So ABA is very much behaviorally based. And it's a little bit more intensive in the sense, unlike speech and occupational therapy, where you're kind of getting it, every week. With ABA therapy, you're able to get it multiple times throughout the week, and then the sessions are usually a little bit longer too. When we look at kind of doing ABA with kids under the age of 5, most of the time it's really taking a naturalistic approach. So instead of sitting them at the table doing kind of tabletop activity, a lot of the play or the therapy should be done in that natural environment where we're following the child's lead, taking material or things that they're interested in, and then trying to teach them new skills through that. And then another portion of ABA is also parent training. So instead of just the therapist working with a child, parents are also having the option of participating or observing, so that they're able to implement some of the things that they learned through therapy for when the therapist is not there. And as kids get older, a lot of them also benefit from school support through kind of an IEP or individualized education program. A lot of them also benefit from special education, which is a much smaller environment where they're able to get more of that one-to-one support that they won't necessarily get from a bigger general education classroom. And then some children, some autistic children may also benefit from specialized medical care, especially if there is any co-occurring medical conditions, or some of the kids I've worked with before in ABA, they also have really significant self-injurious behavior. So sometimes medication intervention is really helpful in those cases. And as these kids get older, a lot of them may also benefit from mental health therapy because, again, we talked about how with older kids, they're really having a hard time understanding some of the nuances in that social relationship. So a lot of times when they get older, they benefit more from that kind of mental health approach, really helping them processing some of the discrepancy of what they think social relationships should be, and then as we know how complicated it actually gets in the real world. And with a lot of these individuals, they do require kind of support across the lifespan. As they get older, these goals of therapy or these focus of therapy will change, because as they get older, their needs will change as well. But sometimes they do require, a lot of of times they do require that ongoing support. And, as you can see, there's no one single therapy that we would say, oh, that's the best therapy for autistic children or autistic individuals. So every one of them has specific strength and it has specific challenges. And then these, again, change over time with their development and how they're responding to kind of therapy services. So we really want to make sure, again, we're focusing on their needs, not necessarily what the label or the diagnosis is. All right, so now we would like you to meet Sandy. This is not Sandy, but this is a very cute picture. So let's say you come to meet Sandy when she is 25 months old, so just a little bit over 2 years old. And some of the kind of the behavior observations that you see just based on that initial meeting is that she doesn't really have any words, so she's not really talking. And every time you call her or her parents call her, she's not necessarily responding to her name. And anytime you try to play with her or smile at her, she's, again, not necessarily responding to that. And then she just has overall really poor eye contact. And then usually when, her parents take her out to the park or when she sees other kids, she sort of just plays by herself. She's not really interested in playing with them. So, based on kind of what we talked about so far, it sounds like she has autism or she's autistic, right? So we want you to keep Sandy in mind for now, and then we'll go back to her later on when we come to learn a little bit more about her.
Okay, so another neurodevelopmental disorder is ADHD, or attention deficit hyperactivity disorder. And this disorder is characterized by a persistent pattern of inattention and or hyperactivity impulsivity that interferes with functioning or development. So there are three types of ADHD. There's the predominantly inattentive presentation, the predominantly hyperactive impulsive presentation, and then a combined presentation involving both the inattentive and the hyperactive impulsive symptoms. So some examples of the of inattention of that presentation, it might include making careless mistakes, having difficulty following through with multi-step directions or instructions, having a hard time concentrating, or maybe losing everyday items. And then some examples, again, not an exhaustive list, of the hyperactive or impulsive symptoms. This might include having a hard time staying seated, interrupting people who are speaking, being on the go or having a high activity level. And then maybe for a child, blurting out the answers in class, maybe before the teacher is done talking. So several of these inattentive or hyperactive impulsive symptoms present in individuals before they're 12 years old. And the American Academy of Pediatrics currently recommends that 4 years old is really the youngest that someone is diagnosed with ADHD. However, for many children, they're diagnosed when they're in their early elementary school years. So in order for someone to meet criteria for this diagnosis, several of these symptoms of either of these categories or a combination of both, they have to present in 2 or more settings. So if someone is just displaying these hyperactive behavior, for example, in the home setting, then they wouldn't meet criteria for ADHD. So for a child, oftentimes we see this is at home and at school. Maybe for someone who's older, they see these symptoms present in the work setting and then maybe when they're with friends. So just 2 or more settings. And we also have to see that there's clear evidence that these symptoms really interfere with their life. And that they're not better explained by another disorder. So many times people who have ADHD do have a co-occurring other disorder, but their symptoms can't be better explained by that disorder. And they also can't be better explained by a specific event that happened to them. And there are different levels of severity for ADHD, from mild to severe, depending on how many symptoms the person presents with. So as ADHD is a neurodevelopmental disorder, it has to do with the way that the individual's brain has developed. Oh, I'm sorry. Can you go back to the other slide for just a second? Thank you. It has to do with the way that the individual's brain has developed, and it's really something that impacts them throughout their life. However, for some people, some of these behaviors or symptoms related to ADHD maybe don't impact them as much as they enter adulthood, particularly with the hyperactive or impulsive symptoms. And it's not that the person has grown out of having ADHD or doesn't have ADHD anymore, but rather that they've learned strategies over time to really manage ADHD. So, for example, an adult, they might be able to stay seated, when they're at work, but they might still have difficulty with concentration or with staying organized. Okay. Thank you. And here are just some myths about ADHD that you might have heard. So the first one is that ADHD isn't a real diagnosis. So some people might say it's just describing bad behaviors, or if they see a child who's really active or impulsive, maybe they say, oh, that's just a kid being a kid. But it is a real diagnosis. We just talked about some of the specific criteria on the last slide. And the second myth is that all individuals with ADHD are hyperactive. As we also just discussed, there are people who have the predominantly inattentive presentation of this disorder. The third myth is that individuals with ADHD cannot pay attention. Well, they can pay attention. Sometimes they maybe need some extra supports, and they might really be particularly able to pay attention if it's something that's really rewarding to them or something that they're really interested in. The fourth myth here is that individuals with ADHD are not smart. This one is also not true. They are just as smart as anyone else who is not diagnosed with ADHD. And then the last one you see here is that medication is the only treatment for ADHD. So it is something that is often recommended, but it is not the only intervention. So now let's talk about what are ADHD focus services. So the first one you'll see here is medication. That is, like I just said, something that is recommended. However, it's usually not the first step, especially with young children. And it's typically something that is talked about more when someone is maybe of school age versus someone who is 4 or on the younger side of just being diagnosed with ADHD. So in addition to medication, another common recommendation is therapy, both behavioral therapy, working directly with the child, and then also therapy that has a parent training component. So of course, this depends on how old the child is, but if the child is really old enough to understand and kind of engage in conversations about ADHD, they might learn from their therapist different strategies to help manage ADHD. So this could be like keeping track of their items or working on maybe not interrupting or not blurting things out, learning how to, remember their homework, for example, and maybe strategies for remaining seated in school. And then also their parents are working with the therapist to learn strategies that they can use in the home environment. So this could be behavior management strategies to help with any challenging or behavior at home. They also may help their child with keeping track of things or helping them follow a routine that they might forget steps for. They might set up a timer and work with them to, over time, kind of increase the amount of time that they're able to remain focused on tasks, just to give a couple of examples. And then you'll also see school services is another common recommendation, either through an IEP, the Individualized Education Program, or a 504 plan. So this would be ways for a child to have either some special education services or accommodations in the classroom. So this might include extra time completing assignments or tests. Maybe they'd be allowed to stand during some of the instructions or have something they can fidget with that helps them pay attention better. They might have a different seat in the classroom. Their teacher might help them break down a more complicated task into smaller steps.
There is a question in the Q&A, as we're talking about kind of some of the ADHD more focused services. So Heather asked, what about nutrition? I wonder if we could get a little bit more clarification on the question. Are you, Heather, specifically asking about kind of how nutrition is impacting, whereas kind of incorporating nutrition as part of this kind of support that we could provide for kids with ADHD? Okay, nutrition on the impact of behaviors.
I can definitely jump in to that. So I think, we talk about myths, and one of the myths was that, like there's a lot of things about like red dye and different things causing ADHD and sugar. What my experience has been, and I think what the research shows, is that sugar can kind of mimic symptoms of ADHD, but it's a spike. It's a quick burst of energy, whereas ADHD is much more of a chronic condition that we see over time and across settings, as Mercedes said. So it's really not something that we link to ADHD, but of course, just like any child, good nutrition is an important part of any, childcare and planning. I don't know if you guys would have anything more to add about that.
Yeah, I would say that, if parents were to ask me about this, I would really recommend that they talk to their pediatrician if they have any, or, go to a nutritionist if they have more specific questions or concerns about that, and if they were interested in other supplements, for example, that they wanted to discuss with the doctor.
There's another question in the chat. Just wondering if you could give some more examples of kind of the environmental controls that parents are able to do, perhaps at home, to help with a child that has ADHD. I mean, Mercedes kind of gave some examples already, but can you like elaborate a little bit more or give like a couple more examples?
Yeah, I would just say, helping them kind of structure their environment and maybe different routines that their parents are asking them to follow. So maybe giving them like one direction at a time, or maybe having a chart or something they can refer to if their parents are asking them to do different tasks at home, like kind of helping them to keep track of things. Or if they're working on attention, again, maybe they can get some type of small reward after they are able to focus for small periods of time that kind of increase over time.
And I would also say maybe just like think about how you're setting up the environment. Like if you know your child, gets distracted easily, so maybe try not having all of his favorite toys out there when you're trying to get him to work on a worksheet. So thinking about how you can structure the environment where, it's a little bit easier for him to kind of pay attention, so he is not getting distracted by the sound of the TV or people cooking in the kitchen and things like that. And then thinking about, instead of having him sit at the kitchen table, could you possibly have him sit at another area where he has his own kind of child-sized table, where again it's easier for him to kind of focus on the task at hand.
Yeah, and another one that Kayla wrote in the chat, visual schedules and first then charts work well too. Thank you.
And I would just add to Kayla's comment, I think, as we talk about like developmentally informed approaches to work, like we want to make sure that the child understands the first then, or if like we're using something like, if you do this, then you get that, like, do they understand that concept? So part of our task is also just knowing where they are developmentally. I think that's important. And then with the parent training component, figuring out sort of what does the parent need? What's their understanding of their child's needs and their sort of competency developmentally, so that as we're asking them to set up things in the home, what other competing things are going on. So that's all part of that environmental control. Like, what does the home look like? One of the great things about COVID, and there weren't many, but one blessing I would say is that we were invited into homes more through remote work. And so we really got to see what that environment looked like. And then I think as we're setting up intervention plans, we could really do a more practical approach to helping them to figure out what was needed to set the child up for success and the family.
And then the other thing I would just also add is that just, from working in like ABA, working directly with the parents for a long time, I would say anything that you implement, whether it's for kids with ADHD or, you know, autistic children, you really have to walk parents through kind of the why. Why are we doing this? Why are we implementing this? How this is going to work? Because they are busy as they are, you know, and then we're adding extra things on their plate, even though these things that might be helping their children. But as we all know, behavior takes time, you know, for changes to happen. So we're not going to see an overnight change immediately. So kind of getting their buy-in, like Megan said, really asking, like, what are their expectations? What is their goal? And how do we meet them halfway so that we are implementing things that will be helpful for them in the long run, but also getting them to actually do it when we're not there. Awesome. All right.
Great questions. Keep them coming.
Okay, so in addition to what you've already heard about Sandy, I want you to also picture that she is very active. She's running around as if she's just driven by a motor, constantly on the go, all over the place. You see her putting things in her mouth, even though she's maybe a little bit too old for that, jumping on her parents, jumping on her teacher. You see her moving around quickly from one toy to another, picking things up, throwing them around. You don't really see a lot of purposeful play with toys. And you also notice that during times of transition, like times to maybe clean up the toys or move on to another activity, she's screaming and having a really hard time. And now I want you to remember these new things about Sandy as we continue to learn about her.
Okay. So as Dana said at the start of our time together, I've been doing this for over 2 decades. And I definitely would say that since I started working in this field, we've always talked about autism. We've always talked about ADHD, but we haven't really done as much talking about trauma until closer to the turn of the century. I think we're doing a much better job of that now. And I'm very glad, because as you'll see through Sandy's story, how important it is to be talking about trauma with every case. No matter what comes through your door, we need to be asking questions about traumatic stress. Traumatic stress, and what it is the physical or emotional response to an event that threatens the life or the physical integrity of the child or somebody who's very important to the child. So it doesn't have to happen to them. Maybe they're witnessing an event that's perceived as traumatic. These events are so overwhelming that they really just deplete the child's capacity to cope. They elicit fears of terror, powerlessness, and just like a physiological over-arousal response. So there's a book called The Body Keeps the Score, and that talks about how our bodies can really hold these events that are traumatic for us, and just the impact that they have on our everyday functioning. It's just such a critical part of understanding when a child's presenting a certain way, that we are thinking about the possibility that they could be impacted by some kind of traumatic event or ongoing events. There's different kinds of trauma. There's a more acute type, maybe a one-time car accident or robbery that was witnessed. Then there's chronic trauma. So these are ongoing stressors like exposure to ongoing domestic violence in the home. There's also complex trauma. So this is multiple traumatic events, maybe different kinds of events. Usually this kind of abuse is something that is happening to the child by somebody known to them. So a family member, a family friend, that's more of a complex trauma presentation. I wish we were all together in one room. And if we were, what I'd encourage you to do, and maybe you can just do this as you're sitting watching your screen, look up, I'm seeing a ceiling tile that looks very much like the one pictured here. And what I'd like to ask you to do is to pretend that a piece of that tile just starts falling down. It falls down next to you in the place where you are. Now, if that happens, you may, just kind of go, oh, got to get that fixed, not a big deal. Maybe your response is, oh gosh, I wonder if there's like big damage to my roof, what's going on? And it's just kind of preoccupying you as we continue talking to you today. Or maybe you're just so distracted by what just happened that you can't even, you know, as great as this presentation is, you have to just stop watching because you're so distraught. And that is really, I think, a good example of the different ways that we all perceive trauma. And an important thing to emphasize, which is that, you know, the definition of a traumatic event really varies, and that we have to make sure that we're understanding it in terms of the person's perception. So, and it really can vary. You can't say, oh, that event happened, therefore we expect this. What we really need to do is take time to understand, to first ask about, did this event happen? And if the answer is yes, then we really want to understand, well, what was that like for you? Things like temperament or personality characteristics all kind of play a part in how somebody may perceive a traumatic event or a stressor. Also, things can change over time. So something that happens at one time point, you know, they may be kind of seemingly okay with it, but like at a different time point, it can come up and either surface for the first time or resurface. So it's really important that we're really looking at the person's response. We also need to be looking very closely at not just the child who's experienced the trauma, but who is on that child's team, who's the caregiver, the family member who's helping the or who's in the role of helping the child to cope. Are they able to do that? Do they provide a sense of protection and safety for the child that's in their care? Maybe they themselves have had some trauma at some point, and so that might make parenting for them very different. And so we want to look at their own histories and how that's impacting their parenting and their care of the child, or even their ability to understand what's going on with the child and meet their needs.
Awesome. Megan, I wonder if you could speak a little bit more about that, because there's a question in the chat asking
Yeah.
about, how about parental oh, sorry, I misread that, prenatal trauma.
Oh,
Okay.
yes.
I read it as parental trauma, and then you were just talking about that. So I think we'll circle back to that question about prenatal trauma in a little bit.
Yeah. Do you want me to address that a little bit now? Okay, well, yeah, actually good intro to the next slide. So it's never too early to be talking about trauma, and certainly at the prenatal level, we know that children are impacted before they're out in the world. In fact, I was visiting my brother-in-law, and he's a really smart guy, and I was telling him about what I do and how I work with kids and do work with early mental health in young kids. And he said, well, how can you do that? They're so little, they're not talking. And so my response was to say, well, what do very little kids, babies, do? They eat, they sleep, and they poop, right? And those are things that they're supposed to do. And one of the things that we can look at is if any one of those things aren't going the way we expect, we can know that that is the way that the infant is telling us, hey, something is not right. I'm not eating well. I'm not hungry. I'm not showing that hunger satiety cycle that we expect in infants. My sleep is disrupted, or maybe I'm constipated, or I have diarrhea. Of course, we always want to look at medical causes for some of these things, but once that has been looked at, the other thing to look at is this child under stress, and is this their way of telling us that? I think another really good indicator is that baby who is so good, and the caregiver comes in and they talk about, oh my gosh, my baby never cries. Well, that would be something to pay attention to and be a red flag, because we know that babies cry. And in fact, they have different cries to tell us different things. And so it's really important that we're looking at, the absence of things as well as the presence of things, and that we're considering the possibility that the baby could be under stress. And absolutely, to go back to that question, prenatal exposure, nonverbal children, all of those things that we think, they don't have to be able to tell us that something has happened for us to know that it's there, and we can look at the signs of that. I think that's really, really important. And again, just because somebody has experienced it doesn't necessarily mean that that there's a causal link. So if somebody, was exposed to domestic violence, the child was, while the parent was pregnant, it doesn't necessarily mean that there's going to be outcomes, but that child already is at higher risk. And we know that about them. And so we want to be looking at, they've had that event. what is their perception and at different time points.
I was just going to add a little bit more to that, kind of like what Megan was talking about. Even if because in my work, I sometimes see siblings that have gone through kind of similar adverse events, but a lot of the times they present very differently. One, their ages might be different, and two, like Megan said, everyone reacts to that event very differently. So I think, we always have to keep that in mind, but not necessarily having the assumption of, oh, just because that happened, this is why he's doing this. It doesn't necessarily, like Megan said, one doesn't cause another. It's important to look at these things, but I don't think we should ever, assume that, that's something that's going to happen just because of that.
Right. And I think, I do see this as a place where we've come, pretty far in our understanding. And it used to be that we thought, oh, well, they weren't talking yet. So therefore that was sort of a protective factor, and it's absolutely not true. And a good example that I like to tell just quickly is we were working with this little baby, and we had a care coordinator, and I know there's some care coordinators out there. And so the care coordinator was a wonderful, very caring person who really loved babies in particular. And she would come up to the baby, and every time she did, that baby would scream uncontrollably. And again, baby, right? Not talking, but telling us something through the cry. And what we sort of kind of arrived at eventually was the fact that the sort of facial characteristics, dark hair, dark glasses, that care coordinator had a similar physicality to the person who had actually caused harm to this baby. And so the baby was making that connection and telling us, hey, I'm uncomfortable. And so the caregiver was wonderful. She kind of changed her hair every time she saw him, took off her glasses, and that really did help the baby be more comfortable. But that's, I think, a one example of the impact that it can have, that we can see happening. And again, it's kind of our job to be paying attention and to be helping as they're doing they're communicating in their way.
There's a kind of a follow-up question to that prenatal trauma or that prenatal exposure specifically. The question is that prenatal trauma has been studied and has been linked to ADHD, hasn't it? And then I believe I remember Karen previous talking about that. So kind of talking a little bit more about like some of that prenatal exposure to, the likelihood of ADHD later on.
We want to address that now?
Sure. You can talk a little bit about that.
Yeah, maybe a little bit. Well, yeah, I think, again, I think you'll see as we go through this talk, the importance of kind of peeling away at the onion and that linkage, because there's so many factors to consider. Was there prenatal substance exposure, for example? What were some of the variables that may be contributing? And have we looked at other factors as we're thinking about ADHD? So I think we can definitely circle back to that, but hopefully our presentation will cover some of those complicated thoughts.
There's a lot of questions in the Q&A about kind of some of the overlaps between, kids with developmental disorders and trauma. So buckle up. We have those coming for you in a little bit.
So these are just some of the characteristics behaviorally that we can see in children who've experienced trauma or stress. Returning to behaviors shown at earlier ages. So again, speaking to that complexity, I don't know if you remember when Yanan was talking about autism, she talked about regression or loss of skills. Well, that is also something we see in children who've experienced trauma. Bedwetting, soiling, thumb sucking, fears of the dark. And again, as we've talked about both ADHD and autism, it's a lot of little kids are scared of the dark. So, let's learn a little bit more about that. We don't want to like over interpret any one behavior, but also we want to understand it. And of course, no matter what, if a child is, fearful of the dark, we want to help them, to feel more comfortable. Loss of skills. We talked about that. Memory problems definitely, I think, can interrupt. And as we talk about the different things going on with attention and concentration, memory is certainly something that can come up with any of the things that we've talked about, but in particular, I think with trauma and ADHD. Just those immature behaviors, so disorganized behavior. You heard about Sandy, how she was running around like she was driven by a motor. Those kind of different things that are happening, the body's like responding to something happening, and we're presenting, the behaviors are presenting very disorganized, and, you know, kind of maybe younger than their age, or changes in behavior. So as we're working with kids, it's really important, if at all possible, to get a good understanding of, you know, when did you start becoming concerned about your child and what were they like before? I think that's super important, because we want to understand if there is a behavior change, when that happened, and maybe what was going on in their world during that time. Difficulties with self-soothing and comforting themselves. So again, thinking about that baby who couldn't sleep or is having trouble eating, just ability to regulate. Fear of separation from your primary caregiver is a very important thing. But again, separating that out from, well, what's typical? You know, what is an 18-month-old supposed to be doing in terms of separation anxiety versus like that more extreme kind of reaction. Even more clingy or dependent behaviors, more aggression than we expect, and again, that level of interference with functioning, more crying and screaming, difficulties with sleep, and then difficulties tolerating frustration. And all of these, of course, in the context of where are they developmentally, what do we expect, and then is this happening more frequently and more intense than we would expect? How much is this interfering? So some specific trauma-informed services that are out there here at Rady Children's. We have the Chadwick Center, which has developed the Trauma Assessment Pathway, or TAP model, which is a really wonderful way of meeting with the family over time and assessing what their presentation is, looking at the histories, looking at kind of everything that's gone on, and developing what they call a unique client picture, so that a specific evidence-based or evidence-informed plan can be developed for that child and family. Whenever we're working with young kids, we're always working with a primary caregiver. So as we talked about earlier, it's going to be really important to understand, you know, what did the parents' own childhood look like? Did they experience trauma at any point, and how is that impacting their relationship? There's a book called The Ghost in the Nursery that looks at that important piece of treating a family, is looking at the caregiver and what they bring to parenting. Some common early intervention therapies that are out there. One is child parent psychotherapy, or CPP. There's also trauma-focused cognitive behavior therapy, or TFCBT, and eye movement desensitization and reprocessing, or EMDR. It's super important, and I think someone had talked about this in the chat when we were talking about autism, about the importance of school services. I think, again, as we've gotten better with talking about trauma and sort of taking away the stigma of talking about it, we're also doing a better job of helping to have everybody who's involved with the child understand what's going on, so that we can understand their behavior. So that child in preschool, for example, who's having that aggressive behavior, who's really dysregulated and impulsive, that if the teacher has an understanding of what may be going on, they can support them in a different way. And then instead of just viewing them as bad or disruptive, they can really, you know, join with others to help support the child in a way that's going to have a much better outcome for them.
I was just going to add that, you know, this really speaks to the kind of the importance of collaboration with other providers, or just kind of support people in this family or in this child's environment. And then just kind of asking people, or asking others, you know, how is that child presenting, you know, at daycare? How are they presenting at the park? How are they presenting at grandma's house? If we're seeing these behaviors consistently happening across different settings, versus, you know, if these behaviors are only happening specifically in one setting, if they're just happening at home, they're not happening at school, or vice versa, that's also really, really good clinical information for us to have. Then that gives us the opportunity to look at, okay, what's different about all these different settings? Where, you know, what's something that's different? Like, how does that change, and why did that change the child's behavior? So again, that collaboration is really, really important, especially when we're working with children that have more of that complicated needs.
And that said too, I think as we're communicating, it's also important to just be very sensitive to the fragility and of the information. And so I think it's also important to be thinking about who has a need to know, why do they have a need to know, what do they need to know? We have to think about things like secondary trauma and all these other things. So it's important that while we're sharing and collaborating, we're doing so very thoughtfully and with intention.
There's a
question. Oh,
okay.
I was going to say, we have a question in the chat. It says, would the trauma assessment pathway be appropriate to use for non-clinical family support staff, for example, home visitors, family strengthening, and service providers?
So the TAP model is actually a specific model that's used here at Rades that is kind of going through a series of meetings with the family by a therapist and the child and family to arrive at what the treatment recommendations and specific services are. So it's really a therapeutic modality and model. That answer that.
Yeah, okay. Hopefully that answers it. If there are any other follow-up questions, please feel free to drop it in the Q&A.
Oh, and there's just one more question that I see here too. Is there specific symptoms of trauma in children with ADHD and autism? That one is another one that we will definitely get to. So hang in there for that one. But before we get there, we did want to give you guys some tools that are out there for assessing trauma. One that we use at our clinic with every child, no matter what their presentation is, whether they're coming in saying, I'm worried about autism, ADHD, or something else. We're always giving them the PEARLS, which is the Pediatric Adverse Childhood Experience and Related Life Events Screener. This is a tool it's very short. It's just a couple, 2 pages, a couple questions, doesn't take very long, but it really gets at asking the questions about stress and trauma that somebody might have experienced. So it's looking at physical trauma, it's looking at emotional neglect and abuse. It's looking at domestic violence, so parental or family dysfunction, and it's very targeted. Now, something to keep in mind is that this tool is asking about events. So it's not asking about symptoms. Remember the tile and the ceiling tile falling down and different perceptions. So this is really, has this happened? Because if it has, then we're going to want to look closer at any symptom presentation. The first part of the tool is really looking at ACEs, Adverse Childhood Experiences, and probably many of you have heard about that. So that's a study that was done here in San Diego at Kaiser Permanente in the 1990s by a physician who was really helping people to lose weight and kind of stumbled upon the fact that there was a correlation between medical issues and other kind of significant life events that were poor outcomes and childhood trauma. And so the ACEs is something that has been replicated across our nation many times over since it was first talked about at Kaiser. And it's something that I think more and more we're incorporating in our conversations when working with families is, has your child had an adverse childhood experience or have you? And in the case of the ACEs, the PEARLS, there are different tools for different ages. In our clinic, because we work with kids under 6, we're asking the parent to be the voice for the child and to fill this out. And they're checking yes or no if their child had experienced this. Page 2 is some new questions that have evolved, looking at things like discrimination, foster care, homelessness, other stressors, in addition to the original ACE questions that have been identified as also contributing to significant concerns for poor outcomes. And these poor outcomes range all the way from medical issues like obesity, where things kind of started with this project, pulmonary issues, cardiac issues, and then other substance use, mental health concerns, depression, anxiety, even early death. So really pretty profound things that we know we need to pay attention to. And asking these questions is just critical in understanding what's going on. And as we talk about the differential diagnosis, so, understanding like the difference between autism and ADHD versus trauma, we first need to say, well, was there a traumatic event? And not asking it could really lead us down an incorrect path. And I'll share how much I value this tool. I was working with a little guy and his mom and in my office really presented very much like a picture of ADHD. And that was sort of the plan that I had. We went on a break, and I was getting ready to start talking about the recommendations for ADHD. And I looked at the pearls, and mom had checked off that the child had been exposed to domestic violence, which is one of the 10 items on the first page. And that is not something that she had brought up in what I consider to be a pretty comprehensive clinical interview at the start. She didn't bring it up. So when I went back, I asked, and she readily shared, oh yeah, well, about 9 months ago, last summer, the father and I had, there had been domestic violence between the two of us. My older son came in and intervened, and there was police called, and this child, my son, had witnessed the whole thing. And that really was a humbling experience. Again, I was grateful to the tool because it allowed me to get that information that would have been a miss, and then would have led the family to a direction of much more specific ADHD focused services, as opposed to where I ended up starting, which was to look at the impact of that stressor on the child and just what was going now with that family system. So I think as much as we can think that we're asking all the questions, having a tool and really using this sort of direct approach can really make a huge difference. So I'm a big proponent of that.
I definitely agree. And there are times when I even directly ask, has your child experienced anything traumatic or stressful? And they say no, because maybe they don't think of whatever the child has experienced as stressful or traumatic until we, introduce this. And also, as someone wrote in the chat, you really have to be prepared when you use this measure for what discussion will come from what they indicate on this. So it's not something where we just look at it and then we kind of put it away in the child's file. We're ready, we're prepared to discuss with the parent whatever has occurred, if they need additional resources, if they need to be referred for, case management or care coordination, or maybe sometimes something might need to be reported. So we really need to, be prepared when we're, reviewing this and talking it over with the family.
I'm glad you brought that up, Mercedes. And I noticed there was some administrators or just program developers in the group here. And I think if you're thinking about incorporating a tool like this, I would recommend it, but also recommend very strongly that there are things put in place to help develop competency for people who are giving this, because it is something that is, it's a little daunting to be asking these questions. It feels intrusive. It feels like, gosh, are we inviting some information that, they want to keep private? Well, we know that that's not true. We know that they're holding it and they want to share it in a safe way, but we also want to make sure that the people that are asking the questions have the support that they need, not only to know what to do next, but also to handle it themselves. So I think that's really important.
There was sorry. I was just gonna say there was another question in the chat asking about how kind of the pearls that we specifically use is different from the ACEs. So I think the pearls is specifically developed to capture some of that events for the child, because we know as we have come to know kind of some of the significance of learning or capturing some of these events, especially for children who are not really, who don't really have the capacity or the verbal language a lot of times to really tell us what happened. So kind of getting some of that information from their parents, and then using that as a way to start some of that conversation, or to really be able to understand their presentation or behaviors a little bit more. And I don't know if you Megan or Mercedes have anything else to add to that.
I do. If you want to go to the next slide, I think that this ACEs Aware is a great website, and the pearls, actually there's different versions. So there's a child version and then there's an older version for adults. So the original ACE, survey that was started at Kaiser was one given to adults, and they said, okay, before 18 years of age, did you experience any of these things? And so that was an adult kind of retrospectively recalling what happened. And again, we've come a long way with trauma and our understanding of trauma, I should say, and talking about it. And now what we're doing is we're actually asking caregivers to be the voice to comment on traumatic events for their children as well. So we have an ACE child version essentially, and then we have one for adults as well. So it's never too late to be asking the questions. And again, our tools have, I think, been refined to really, you know, make sure that we're asking at all ages. And as Yanan said, you know, or Mercedes said, I think too, like, you know, we may ask it one time and we may get one response. And so it's really thinking about, like, you know, sometimes it's asking it a couple times before the family may be ready, or, you know, the direct way and the specific way that the ACE and the pearls ask the questions, I think may invite it, along with that compassionate person who is there with the family, ready to receive that information that is so sensitive and so personal. But ACE is Aware is a great website. So pictured here, if you have 16 minutes for a really good TED Talk, Dr. Nadine Burke-Harris here on the left was the first Surgeon General of California, and she has really done a lot to champion use of the ACEs in the medical and mental health fields. She was the first to bring this whole protocol of providing training, introducing the pearls, refining it with that second page where there's more about toxic stress and other adverse experiences. So there's a lot more information to equip providers with how to bring the questions about trauma into a medical and mental health setting. In fact, she believes so strongly in this initiative that she also paid providers to give the tool. So if you give the tool, there's a $29 payment that the state of California will give for all Medi-Cal recipients who take this, who complete this tool. And so that's really important. And ACEs also has a wealth of information about treatment because of course it's so important, not just in identifying things, but in understanding like what can we do to support the next steps once we've had that conversation. And I think the other thing that I just would want to mention here is that, you know, just like autism and ADHD, ACEs does not discriminate. It can happen to anybody. An adverse childhood experience can happen to anybody. And so we want to be asking these questions to everybody who's coming through our office and that we're talking with. We know that about 63% of Californians have experienced at least one adverse childhood experience, and nearly 18% have faced 4 or more. So those are pretty significant statistics. The original study was, you know, as I mentioned, was done at Kaiser. That's a middle class population, predominantly white patients who were showing high scores on the tool that was used. And so I think it's very important that we're, again, bringing this up with everybody and not just like thinking, oh, well, this is how they're presenting, or these are the questions, you know, that I'm being asked. It doesn't matter if you're being asked about ADHD or autism, or if everybody's saying everything's fine, we still need to be asking this to every patient every time.
And then that's actually kind of how we introduce the pearls to our families when we do administer them. We do that for all of our families. So kind of that's what we tell them, you know, this is a measure that we give to all the families and, you know, kids that we see, is to really look at some of these events. And then really, we're not trying to be nosy here. We're just trying to understand you, your child, your family a little bit more so that we're able to kind of point you guys in the right direction in terms of services. We're really connecting you guys with additional therapy if we need to. There's a question in the Q&A in relates to that. Is there a tool that can be used by children or adolescents to assess trauma?
There are, and I can drop some. I can drop a tool that we use, the child, the CFT. Let's see,
The child
family. Gosh, I'm blanking on it right this moment. I'll
Trauma
drop it
symptom
in the chat.
checklists for young children.
Thank you. Yes.
Mhm.
So we can drop that in the chat. That's the one that we like at our clinic the best because it goes down for very young children. But there are others, and I can definitely drop some names of different tools in the chat before our time ends today.
And I would say the pearls for the ACEs, you know, you don't have to just give one or the other. Like with KidStart, the other program that I work with within Radies, when they get into the program, we're not just looking at the child's pearl scores, but we're also giving the actual adult ACEs to the parents as well. So kind of talking about kind of what Megan was, you know, saying before, the ghost in the nursery. What are some of the events that happen to the parents that could potentially impact their relationship with their child, or how they're parenting and things like that. So the pearls or the ACEs really just serve as a screener for us to start addressing some of these things, and then really kind of give them more in-depth trauma measures when we do feel like there's a clinical need for it. There's another question in the chat, like the ACEs, do you just ask the score, or do you dig into the details of their answers?
So glad you asked that. So ACE study says the kind of the research on the ACEs says that a score of 4 or more is linked to kind of a clear significant concern for increased poor outcomes, like we were talking about medical issues, mental health issues, and other kind of poor events. But I think even if you have an ACE score of 1, you need to understand how is that impacting the child. So we can't just say, oh, it's just a 1, that's okay. No, we need to understand, no matter what that is, the impact of on the child and the family, and how that's being perceived, and to the degree that it's impacting their functioning. So I think that's really important. The score, just like anything that we do clinically, we don't want to put too much weight on a score. We have to understand really the whole picture and the context of everything, and how that child's doing. So that's a great question. I'm so glad you asked that.
And I just want to add, also, we follow up because some of the items are very straightforward, kind of like a yes or no question, and then other ones, they can check one box for if a couple of different things have occurred. So it's really important to clarify what they are referring to. And I've also had some people who maybe check a box, but then when I ask more about what exactly happened, they maybe misinterpreted that question. So that's really important to have that discussion, so I'm not thinking one thing when really something else happened.
Oh, that's a really good point. Yeah. It's the pearls is really meant to start the conversation and then to understand more, but also don't feel like you have to get everything all in one setting too. And remember that idea of collaboration and passing the baton to the next person. So a lot of times we're identifying, hey, I'm worried that this child is having a traumatic reaction to an event. And so I'm going to refer for further assessment. And that's where that TAP model, that's where trauma-informed therapy and really ongoing assessment is so critical and important. So Yanan first introduced you to Sandy, and we described her as a child who showed a lot of autistic symptoms. And then as Mercedes talked and we reintroduced her, it really sounded like, gosh, she was also showing some signs of ADHD. Well, now imagine, that we've learned even more about her history and her story. We know that she was removed from her mom and placed in an emergency shelter, and then she was placed in a resource home. So she's had a lot of disruptions in her with her primary caregivers and in her home life. Before removal, she was exposed to parental domestic violence. Her parents separated when she was 2 months old. Her father is currently incarcerated. Both of her parents have a history of substance abuse, and her older and her younger brothers both have developmental delays with behavior problems, and autism is suspected for them. We also learned that the birth mom, reports that she herself was diagnosed with ADHD as an adult. So lots more going on with Sandy than originally was known. And I think that's going to be important as we're thinking about her.
So now, knowing all these information about Sandy, we would love for you to continue to have this discussion with us. Imagine, in your role right now, how would you kind of approach this family? How would you help Sandy? And also, as we kind of started to learn more and more about her, kind of how did learning each of these additional kind of piece of information change your perspective of what you would do with her? How did that change Sandy's needs in terms of how you looked at her? And then what would you prioritize? Because we know with families that have higher needs, they are often very overwhelmed. So if you could prioritize 1 or 2 things for Sandy and her family, what would that be? And not just thinking about kind of from a broader perspective, are there things that you're doing in your line of work that already work well with families like Sandy? Like, what are some of the things that you guys are doing that are working? We want to know. And then what are some of the things that are maybe not going so well? What are some of the challenges? Because we know it's always easier to talk about implementing something than it is to implement it. So we would also love to hear kind of some of the challenges as well. So we're gonna quickly go into a 10-minute breakout group so that we can have kind of a smaller group discussion. We love to hear what you think, and then we'll come back to our main group, and then hopefully we'll get some really good discussion going. Okay, so we've got some really good discussion in a smaller breakout group, and we just wanted to see if anyone, maybe one or two person, would like to share a little bit more about kind of some of the discussion that you've had with your group. You're more than welcome to unmute yourself if you're able to. We're getting a little bit shy.
Well, we were just talking with Roberta and she said that, she said, you stole my Sandy, but she's met, there's a lot of Sandys out there. I think that was something that was acknowledged, and, how important it is. I think the other thing that came out of our group was just that education piece, whether it's with school personnel, resource parents, foster parents, birth parents who have their own stories, lots of things that, that education piece is just so critical in understanding the behavior so that we don't jump to kind of not just a misdiagnosis, but misunderstanding, like this child is bad, this child is purposefully disrupting nap time and things like that that came up. So important, I think, to really look at the layers of what's going on and to make sure that we're educating people, teachers, everybody working with our kids. Looks like Pamela's got her hand raised.
Yeah, I wasn't so much going to share all of the different things that were discussed in my group, but I do want to say that as a clinician, it's a big struggle to get diagnosis for kids that can actually have all three of these things, because it feels like whether it's the school, a third party, a regional center, that does the assessment, they're always ruling stuff out based on the other one, as if the three cannot coexist, the three diagnoses.
I think that's a really great point. So when I kind of a lot of the developmental evaluations I do through KidStart, which is a program that, primarily work with kids that have complicated psychosocial or medical and mental health needs, that's really the scenario I get into a lot. They come in for the initial assessment. I see all these needs, and then sometimes parents are really looking for a specific diagnosis because that really helps them understand their child. Like, what is it? And then that's the question they ask me. And then sometimes at the end of the evaluation, I don't know. It could be this, it could be that. And then, like you said, it could be both of those things or all three of these things. And then, so I think this is a good segue for us to kind of start talking about, okay, what are some of the overlaps that we see with all these different things?
Yeah. So kind of moving on here, we're going to talk now about the overlap of ADHD and trauma. So trauma-related disorders and ADHD, they have distinct symptoms and behaviors, but also some that overlap that you can see here in the middle of this Venn diagram here. So people with each of these disorders can present with executive functioning difficulties and behavioral challenges. But depending on which disorder they have, there's different reasons why the person is presenting this way. So it could be something that has happened to them in their life, or the way that their brain has developed before they were born. And we especially see this overlap in children. So maybe someone who is a little bit older and has maybe more verbal abilities, they can explain maybe what they're experiencing, they can process it. If they're seen maybe staring off or something, they can maybe tell you a little bit more about what they're experiencing in that moment. But with children, we often do see a lot of these behavioral signs that can make it a little bit more difficult to understand, exactly what is going on. And we also know that some brain imaging research studies have shown that there are similar irregularities for both trauma exposure and ADHD in these brain imaging studies. And so some of the overlapping symptoms or behaviors can be difficulty concentrating, maybe having a hard time learning and paying attention in school, appearing easily distracted. Maybe when you're talking, they don't really seem like they're listening or paying attention to you. They might have challenges with remaining organized. You might see that they have a high activity level. They're really hyperactive, having a hard time staying seated, restless, fidgety, and maybe having a hard time falling asleep and staying asleep. So a lot of these, there's many different behaviors that we can see that overlap with these two different disorders. So it's really important to identify, though, what is responsible for the child's behavior? Is it one or the other, or is it both? So if we have a good understanding of what the child is experiencing, it can impact treatment and recommendations that we, suggest to the family. So just one example is that if someone is prescribed maybe a stimulant medication for ADHD, maybe this can increase their trauma-related anxiety. So maybe a doctor would suggest maybe a different medication that might be better for that child. We also know that each disorder here can increase the severity of the other. So experiencing trauma can make ADHD symptoms more pronounced, for just as one example. We also know that intervention in one area can help with the other. So if someone is in therapy, they're learning emotion identification skills, coping skills, they're learning how to kind of talk through their internal experiences. These skills can also translate to helping them better understand and communicate their experience with ADHD, and maybe put some of those skills to work in terms of managing ADHD.
Now looking at kind of some of the overlaps and extinctions or distinctions between, autism spectrum disorder and trauma. As you can see in the middle, there's a lot of overlaps, right? So we have limited interaction with other people, just really kind of not very interested in that social component, and having limited range of facial expression, and are really not having that desire to share their emotion or their affect. And a lot of times we see difficulties regulating their emotions, difficulties with transitions, and then some more of that repetitive play. We're wanting things to stay the same, wanting to do the same thing over and over again. And then we often see sleep difficulties, kind of that sleep disturbance. And then again, kind of a lot of those more like intensive outbursts or tantrum behaviors. Sometimes a lot of these individuals have self-injurious behaviors. And then while looking at that, there are also a lot of kind of distinctions between a person or individual that just has autism or that's autistic, and then a person that also has trauma, right? Some of the things that we know is that autism is a lifelong kind of just kind of the nature of the diagnosis itself. It's not something that they would just kind of grow out of, right? So even though the restricted interests might change, when they're younger, it might be dinosaurs. When they get older, it might be empire penguins or something different. But these kind of core features will stay the same. So we'll see these things evolve, but they are sort of like still there, and then they're still impacting, the individual's daily functioning. And then a lot of times we see these behaviors kind of start happening before the age of 3. So they're happening kind of at a younger age, and then they're persistent over time. While when we are looking at trauma, it could look very different over time. So sometimes, when we're seeing someone young that has experienced a traumatic experience, we might see them having higher needs at one point. But then once some of these behaviors kind of start to subside a little bit, through intervention services or through therapy, again, we should really see kind of a decrease in those symptoms. However, later on, as they get older, or something else happens in their environment that reminds me of that adverse event, we might see these behaviors happening again. So again, kind of that's some of the difference, where with autism, we see kind of it consistently happening across the lifespan, versus trauma, we may see it come and go depending on what's going on in their environment. And then some of the other specific kind of characteristics for trauma exposure or childhood trauma stress is that, we're seeing more of that maybe more flashbacks, or maybe the child's having more nightmares. So the nightmare here is very different from kind of just the sleep disturbance that we see with autistic children. The nightmares are a little bit more intense. They happen more often. Sometimes they happen more or less around, kind of when the actual like event was happening, or the anniversary of the event, and then things like that. And then we tend to see more of kind of a different attachment style in these individuals as well. Sometimes they're a little bit more withdrawn, other times they're a little bit more like too familiar. Again, they're having a hard time understanding kind of what is appropriate in that social content. There is one question in the Q&A, and then I think, Megan, that was something that we talked about with Mercedes too when we're reviewing the slides. Many folks in the autistic community talk about trauma impact of being neurodivergent in the neurotypical world. Just wondering if we could speak a little bit more on that.
Yeah, so just the trauma of being neurodivergent and just the experience of being othered or, not belonging. I think that's super important. I mean, just the overlap is so profound. We just know that autistics are more likely to experience post-traumatic stress than the general population, especially women, genderqueer people, Black, Indigenous people of color autistics. All of the people that tend to sometimes be marginalized are at greater risk for experiencing trauma, and so I think that's something that we need to really pay attention to. Autistic women are 1.5 times more likely to be victimized than their autistic peers, so that's another thing to be thinking about. And yeah, I think coupling that with just again, hopefully, and you're gonna see in a slide that we talk about that we have come far with sort of celebrating neurodiversity and recognizing the broader spectrum of humankind in a more inclusive way. So I think we have a ways to go, but we're getting better there. But I do think that complicates things more. If you have one thing that's already making you different, and then there's something else too, then that's going to be more challenging for sure for that person. Definitely. So this slide just talks about, and I do want to acknowledge the comment in the slide about the tag your it comment. I think the idea of you can have autism or ADHD or trauma or both or all three of those things, and it's not easy to figure out what's going on, and yet super important because we know, as we talked about, one can kind of relate to the other. Autistic people being more at risk for trauma, ADHD also being at higher risk for trauma as well. Those behaviors can be very difficult to parent, and that can put a child at increased risk for abuse and neglect. We look at the impact, though, of trauma on brain development and how complicated it is. When we think about autism and ADHD as a neurodevelopmental disorder, something that impacts the brain, we also know that that's true in trauma. And if you look here on the left side of the screen, an image of a 3-year-old child, one with extreme neglect, and you see the size of that brain, and then one without, and the difference in size, the physical difference, the impact there. And so how that's going to impact the presentation of a child is going to be really important. And what does that look like developmentally and behaviorally? Well, if you look at the right side, and studies that we did with Romanian orphans who were later adopted, this was back in 1999, these 4-year-olds who were in very deprived situations in orphanages where they had no physical contact, no attachment, and were really just in very severe situations. They looked very autistic, and not just autistic in the ways of like, rocking behavior or things that we might see for somebody who has had like deprivation, and things like that. But they also showed some real autistic characteristics like preoccupation with certain objects and certain sensory kind of responses. And so they really did look autistic, but changed over time. And so they talked about quasi-autistic presentations of these children. And I think, as we do our best not to say tag your it, let's have the next person figure this out. We also don't want to jump to conclusions and say it's everything. And so sometimes it is about sort of peeling away at the layers and saying, okay, well, where do we want to start? We know there's trauma here in this child's presentation. So let's start with, a trauma-focused approach to intervention. And then let's see what's next. We talk about the child helping us to do the assessment. They tell us what's going on with them by their response to intervention, and that assessment over time just being so critical. So what to do for Sandy? You know, if she were a child who just had autism, that would be one direction. If she were a child who just had ADHD, that would be one. She's a child with that complex presentation. And so again, that's where we want to take time to really look at what her needs are. Where can we start? Thinking about the family, where can they start? You know, I've worked with many families and all they can do is one thing at a time. So what is that one thing? Where do we want to start? What does Sandy have in terms of her skills? Does she have play skills? If she does not, then maybe some more behavioral approach with somebody who's also trauma informed is going to be important. But if she does have some play skills, maybe more of a trauma informed approach is going to be a starting place. And then we'll keep looking at what are her symptoms of autism and ADHD looking like. That assessment over time is, I think, the best thing that we can do for Sandy, and to really look at how she's responding, and to think about the whole family and what they can handle.
So we talked a lot about needs, challenges, deficits, impairment, but we also have to realize that it's not just about that, right? So think about it. A lot of the times, these things that we see in our office or in your session with with the child for like 50 minutes or 2 hours or 3 hours for the evaluation, parents see that a lot of the times 24/7. So imagine how overwhelming they are and how hard it could be for them to really see their child, outside of these behaviors. So they really experience these struggles on a daily basis. So as, outsiders, we really need to be taking a strength-based approach. What are things that they are good at? They have the greatest smile, they have the best giggles. So things like that, even just small things like that, really kind of taking that strength-based approach, help the families see the hope, helps them see the child behind these behaviors and these struggles, and really help them build resilience to reduce, kind of future risk. We talked a lot about, looking at the Pearl score, we're looking at their adverse events, but when we're looking at these things, we're also looking at these protective factors. What are some of the things that could actually help mitigate some of these events that had happened? Because we cannot undo trauma, right? If we could, obviously we would, but it's just not possible. So we need to be thinking about, how do we identify these protective factors? How do we create more protective factors for them? Or how do we become the protective factors for them? And then these do not have to be big, significant things. We're not going to be able to solve all of these problems or these challenges overnight, but these are things that we might be doing already. So things that we can work on connecting with the families with. Are they in school? If they need support in the school, can we get them an individualized education program? Are there other people in their environment that could become their support person? Really help them build the village that they need to really focus on their child's needs, and then being able to go from there.
Okay, so here are some people or characters portrayed in the media, or just popular people who have different neurodevelopmental disorders. So on the left, we have Sheldon from the Big Bang Theory TV show. We have Michael Phelps in the middle, the Olympic swimmer, who's talked about his experience with ADHD. And then on the right, we have Love on the Spectrum, the popular Netflix show. And so oftentimes, we see people portrayed in the media as having really, especially autistic people, they're portrayed as having really unique and exceptional talents. They're portrayed as being a genius or a savant. Like Sheldon from, Big Bang Theory. And it's just really important to remember that not all autistic people are geniuses or savants. We see on Love on the Spectrum, that TV show, that people are represented who have different abilities, like different verbal abilities, different, some live independently, some do not. They have different intellectual abilities. So it's really, this is an example of kind of the media doing a little bit of a better job, maybe showing diversity in people's presentations. And just to remember that people who have these different neurodevelopmental disorders are just as diverse as, the rest of the population. So we also, it's just important in our work that we really, instead of focusing on that one exceptional skill, that we focus on really identifying the individual's unique interests, their strengths and their abilities, and just really helping them to find a support system and network that can really, that's familiar with their challenges, but also can really promote positive outcomes for that person.
And when I'm making recommendations to families too, I'll often include information about neurodiversity too. I think that's super important. So we talked about, just education being such a critical factor. I think if we can educate them about neurodiversity, parents just coming into this, that can be a huge gift.
Mm-hmm. Yeah, so looking forward, looking at, some of these positive improvements in society. One is the emergence of the neurodiversity movement. So this is, a recent movement to really understand autism, ADHD, and other neurodevelopmental disorders as differences rather than deficits within the person. And one impact of this movement has been some changes to the language that we use. We've talked about this earlier in the presentation. After hearing autistic adults' experiences and preference to be referred to as autistic adults or autistic people rather than a person with autism, really capturing that, it's a part of their identity and not, a separate piece or something that's separate, from them. And another positive improvement in society has been that recently some major companies such as Microsoft, Ford, Walgreens, just to name a few, they've really made some changes to their hiring practices, recognizing that in a traditional hiring practices or in a traditional interview, it really relies on a lot of excellent communication skills and a lot of conversation. And someone might be a really excellent fit for a particular position, but they might not have those skills that are really highlighted in that traditional interview. So more so focusing on visual spatial skills, technical math skills, or other things that would help them be successful for that job, rather than focusing on so much on the interview. And you'll also see another positive improvement has really been efforts to destigmatize trauma and talking about traumatic experiences. So the blue pinwheel here is a national symbol for child abuse prevention, and April is Child Abuse Prevention Month. So this is really an effort to bring people's awareness to talking about trauma, and the pinwheels were chosen to reflect the bright future that all children deserve. So we just wanted to highlight here, just again, looking forward, some of these positive changes and that society is making to be more inclusive and to really just highlight neurodiversity and to bring awareness of people's experiences.
And next month is April, so one thing you could do, as early as next week is to have a blue pinwheel just displayed in your offices, and that would be something that would be sending a pretty powerful message. All right. Well, I know we've got like 6 minutes and a couple questions in the chat. Should we go for those and then we can take further questions?
Mm-hmm.
See, the first one that I see is, when is the DSM going to update some of their diagnoses to better capture some of the profiles of child trauma? It's a great question. I think
really
they are due for an update. It comes out about every 10 years. It takes a long time, right, for a bunch of smart people to get into a room and figure out what the new diagnoses are going to be. But I think the revisions are likely to be soon. So I haven't heard of a revision to the DSM-TR, but DSM-5-TR, but I'm sure it's not long. Have you guys heard anything else?
No, I mean, we just had the the newest would be kind of the change to the autism diagnostic criteria, right? So kind of really thinking about how long that took, you know, to happen, and really thinking about kind of some of the rationale behind that, you know, looking at the levels, thinking of them as the needs for the individual. And I think, again, that kind of speaks to the importance of not, you know, as much as we sometimes label does help explain things, but really rather focus on needs, especially if we don't have, you know, enough in the diagnostic criteria to really give us a clear cut of like, this is what it is. So kind of, you know, trying to understand that and educate other people that are working with the family to really focus on that. I think it's something that we could do in the meantime.
Right. Well, as we think about, so the DSM-5, I think it was 2013 that came out, and the really big changes with like the word autism and that autism spectrum disorder and all the changes there. Then we had the text revision several years later, and there were some, I think, modifications that speak to how important language is. So just terminology like intellectual developmental disorder is a new term that we're using. You know, we used to use the term mental retardation before. And so I feel like those people that are involved in the development of the DSM are paying attention to language, you know, as evidenced by the revision. But in terms of when we'll get a DSM-6, I'm not too sure. But you know, I'm sure it's as soon as they finish one revision, I'm sure that's kind of what, you know, in the works. But I haven't heard. But I agree with you 100%. There's more to do in the work of childhood trauma and capturing that. And those of you familiar with the DC 0 to 5 diagnostic classification system there, that does have some better ways, I think, of capturing childhood disorders for our youngest kids, but there's more work to be done for sure. The other question here is, what are your thoughts on child and family traumatic stress intervention? My CAC has 3 people going through a training on this right now. I can speak a little bit to this, but Yanan and Mercedes, do you want to?
I don't know much about this,
Yeah.
I will be honest. So please go ahead.
Yeah, and our hats are really more diagnosticians as psychologists, but you know, and the folks that we work with don't use this. I think it's a treatment intervention for slightly older school-age children, is my understanding. And the only other thing I know about it that I would comment on is I believe it's something done soon after the traumatic event, and it's pretty brief. So while it's important in terms of stabilizing and addressing needs as soon as possible, it would also be important to make sure that the needs are identified as that therapy is winding up, and like, what are the next steps? Do they need more longer term therapy? I mean, I think would be something I would want to be thinking about. We have that model here in San Diego where we have some folks that do kind of brief stabilization programs, and then there's sort of a pass off to some of the other longer term folks. So I think that collaboration is really important.
There's another question on what about your thoughts about adding developmental trauma disorder to the next revision of the DSM, and then the implications for kids' diagnosis moving forward?
Developmental trauma. Well, I think I'd want to know a little bit more. I'd love to talk about that. I mean, I think, you know, we always talk about having a developmentally informed and a trauma informed approach to our work. So I'm not sure if when you're asking about that, if you're talking about, you know, that there's developmental delay and trauma. I mean, I think that does go hand in hand with trauma as we know it already. And so I don't know. I mean, I'd be interested to have more of a conversation about that for sure.
Absolutely. I think that's all the questions we have in the Q&A.
We answered some questions in the chat about some questions about developmental screeners or autism screeners. So you can look in the chat for those.
And I wanted to look back to the question about the symptom checklist. So it is called the trauma symptom checklist for young children. I put that in the chat. Well, we like that one because it goes down to age 3 and up to age 12. There's an older version too that goes up to from 8 to 16 trauma symptom checklist for children, but then there's the younger children version. There's not a lot of measures out there for young kids that are looking at symptoms though. So I think that's important, and really making sure as you're choosing measures, you know, is it an event? Is it capturing events like the ACEs and the PEARLs? or is it capturing symptoms? And what do you really need? I think most importantly, you need a trusting relationship with the family and an inviting provider who's competent to have a conversation and to start the conversation, and then knowledge to, where to go next. Because really, if there is a traumatic kind of piece to the child's presentation, that's not going to be something that one checklist is going to help you understand. You're going to want to really look at that over time.
In relation to that, I know we're out of time. I just wanted to comment really quickly. There was a question before about how do you write up reports, or like how do you report about trauma in your, I guess, your report, like particularly when you're going to a school. So I've actually had this happen to me quite a few times where I think, Megan talked about who needs to know, why do they need to know, and I would also encourage you to think about how much do they need to know. So like with school, could we just keep it in general where they've gone through some traumatic events, or do we really have to spill out all the details for them? So I think really think about what is the reason for them to know, and then how is knowing that information going to help them help the child. That's probably kind of the base of sort of like for some of the decisions around that. And then in my practice, not in our clinic, what I've done before is I've also not necessarily modified but report, but taking out certain sensitive information from the report so that the families can share with school or other people that don't necessarily have to know that very kind of specific sensitive information, but also getting the general idea of like what the child's needs are. So again, it really depends on who's getting that information and why they need it.
Yeah, good point. We have one more slide there to wrap up.
Yeah.
All right, we have made it exactly to 4 o'clock, and I want to thank everyone who's joined us today for joining us for this great 2-hour presentation, and for participating really actively. We saw in the breakout rooms and really thinking about this case study and how it might apply back to your own work with children and families, your organization, your community partners even, how those pathways look, so that you don't have that tag you're it situation. And I also want to thank Yana, Mercedes, and Megan for lending their deep expertise today, which was far-ranging. I think they covered a lot of ground, both on the various disorders, how they connect with trauma, and then lots of other questions that are related to that. So we are truly appreciative, and hope that they will join us again in the very near future for another training. We do have the survey and certificate in the chat. And once you open that, you do not need to stay on the webinar. You can keep that open and provide all of the feedback that you want to share with us so that we can continue planning great training for you. I hope you all have a wonderful afternoon, and we hope to see you again very soon.